All right, so I would like to go ahead and introduce our speaker today on approaching pain using psychologically informed practice. So Dr. Jason Beneček is presenting today. He is an assistant professor in the Department of Physical Therapy at the University of Florida and clinical research scientist at Brooks Rehabilitation. Dr. Beneček received his Doctor of Physical Therapy degree from the University of St. Augustine for Health Sciences in 2002, where he also completed an orthopedic manual physical therapy fellowship. He received his PhD in rehabilitation science and his MPH with an epidemiology concentration in 2011 from the University of Florida, where he was supported by a National Institutes of Health T32 pre-doctoral fellowship. He is now the current director and clinical investigator with a musculoskeletal concentration in the Brooks Public Health and Human Performance Research Collaboration, which is a partnership between Brooks Rehabilitation in Jacksonville, Florida, and the College of Public Health and Health Professions at the University of Florida. Dr. Beneček has been supported by the National Institutes of Health K-12 Rehabilitation Research Career Development Program, the Patient-Centered Outcomes Research Institute, the Center on Health Services Training and Research, and the Foundation for Physical Therapy Research. His research interests focus on secondary prevention of musculoskeletal pain and include risk stratification approaches, psychologically informed physical therapy, and implementation science. He currently teaches evidence-based practice in the entry-level Doctor of Physical Therapy program at the University of Florida and is a faculty member in the Brooks Rehabilitation Institute of Higher Learning. Dr. Beneček currently serves as an editorial board member for Physical Therapy Journal and international editorial review board member for the Journal of Orthopedic and Sports Physical Therapy. So without further ado, I will go ahead and hand it off today to Dr. Jason Beneček. And whenever you're ready to share your screen, we'll go ahead and allow you to take on over.
Thanks, Natalie. Can you see my slides?
Yes, looks great.
Okay, great. Thank you. Thanks again, Natalie, and for the nice introduction. And thanks everybody for joining us tonight for this presentation. Focus is going to be on psychologically informed practice. And as Natalie has indicated, I was trained as a physical therapist. So a lot of the clinicians I commonly communicate with, work with, are physical therapists. We've also worked with physicians and clinical psychologists, but just keep that in mind as we move forward. A lot of the work that we've done in this area has really focused on physical therapy and working with physical therapists. I, like Natalie, would also like to acknowledge the AI-PAMI, and information is provided here with a link to the website, as well as contact information. So I encourage you to go on the website, check it out, and look at all the interesting information they have to provide. Great resources. So to get started with psychologically informed practice, and really what do we mean by this term? This term has really been introduced into the discipline of physical therapy probably about 10 years ago. And it all started with a special issue in the Physical Therapy Journal. And the focus of psychologically informed practice was really centered around low back pain, which kind of makes sense because, as most of us know, musculoskeletal pain is the most prevalent type of pain, and low back pain is the most common type of musculoskeletal pain. And why I really like presenting this figure here is it really provides a general concept of what we mean by psychologically informed practice. Those of you that are not physical therapists may or may not know, most physical therapists were trained, including myself, and I will still argue that a lot of them are still trained based on the philosophy on the left, outlined by a red box, where physical therapists are taught to address physical impairments, identify tissues that are potential source of pain, with the primary goal being to reduce symptoms through either manual therapy, exercise, patient education, or physical modalities. If we look at the far right, mental health practice, imagine that being your clinical psychologist. And their core philosophy is a little different. Their core philosophy involves identifying and treating mental illness, depression as an example, anxiety as another example. So one of the key messages from the onset that I think is important for us to get across is that we are not educating or promoting physical therapists to be clinical psychologists. That's not what we're doing at all. What we are doing, though, is we're using psychological-based principles and merging them with what physical therapists do as part of clinical practice, which is where we kind of find ourselves in the middle, outlined by the yellow and blue box, psychologically informed practice, where the core philosophy involves incorporating patient beliefs. I will also add clinician beliefs, attitudes, and emotional responses into patient management. Now, those of you that have an understanding and a little knowledge about the FLAG initiative that was introduced in late 70s, early 80s, you might be familiar with the terms red flags, yellow flags, blue flags, and orange flags. And it was really intentional in terms of how these boxes were outlined and the colors that were used. For example, physical therapists are traditionally trained to identify red flags to understand if the patient is appropriate for physical therapy services. If not, they need to get referred to a physician, for example. On the far right, those are your orange flags. Those are psychological factors such as depression, different than depressive symptoms, anxiety, potentially anger. But then if we look at the middle, outlined in the blue and the yellow flags are the flags that are now gaining popularity in the discipline of physical therapy, that include constructs such as pain-related fear, kinesiophobia, fear avoidant beliefs, pain catastrophizing. And then the blue box is really related to work-related factors, which are not as commonly addressed, screened for, and managed by physical therapists. But again, common to what certain types of physical therapists may assess, may manage. So this kind of provides the precedence for what we mean by psychologically informed practice. This is a model that we have kind of developed over the past several years, and this is kind of the big picture here, where we have our patients on the left, and let's say those are patients over the course of a month that, let's say, a physical therapist, and I would also say that potentially a primary care physician, family medicine physician, I would even go far as to say a physician in the emergency department. They may see that is experiencing, let's say, low back pain, for example. We then attempt to identify patient subgroups. There's a lot of different ways that we can subgroup patients. The model that we have focused on relates to risk stratification, and patients are subgrouped based on prognostic factors. We'll get back to that in a little bit, but that's one of the things that clinicians have told us they really like about this model. These are prognostic factors that can be addressed specifically by physical therapists. We'll get back to that in a little bit. Based on that, then patients are treated differently based on their risk for poor outcomes, right? They could have low risk for poor outcomes, they could have immediate risk, or they could have a high risk for poor outcomes. And that's where we kind of move over to the far right, and we kind of name this figure here our PIP pie, if you will, that you can see is outlined by the crust, which is really deserves a lot of attention, and that is patient-centered communication. And then the different slices of the pie include different types of interventions. An important component of psychologically informed practice is clinicians need to monitor how patients respond to treatment. They need to do it early, and they need to do it often during the episode of care. And then something new that we've kind of added is this intensity dial, meaning that a lot of times we focus on the high-risk patients. But in the grand scheme of things, if we really consider all of our patients could really benefit from components of this PIP circle/pie, if you will. The difference is how much of what is appropriate for each patient. And that's when we really talk about providing tailored treatment based on individual patients and based on specific patient profiles. So why the focus on psychological factors? This is important to kind of, again, provide a rationale for why we're focusing on psychological factors. So again, imagine this being a group of patients with, we can use low back pain again as an example, and we provided them with the same type of painful stimulus. In this case, it was heat, same intensity. We expose them to it for the same duration of time in the same location on their body. I believe this was on their forearm. Okay, 49 degrees Celsius is pretty hot. I will tell you, I've experienced it. We then asked these folks to provide a pain intensity rating. And what we see here is, again, this is real data, the variability in pain intensity ratings for this group of patients. Now, I will tell you, this is a normal phenomenon. And I think a lot of times patients may not realize this. I would also say, based on previous experience, there are even some clinicians that may think this is not common, and that patients that have an experience, knee pain, low back pain, shoulder pain, whatever the case may be, they may think that, well, if we're dealing with a patient that has chronic symptoms, they should all be experiencing, let's say, pain intensity that is extremely high. And that's not the case. Okay, so why are we using this as an example? In our minds, the reason why is that this high variability in pain experiences is evident. And it's evident even with the same peripheral pain generator. In our previous example, we used heat as the pain generator. So a rationale for this is somewhat of a paradigm shift for physical therapy in particular, in that identifying the source of the pain may not be that important. Now, before people start saying, well, how could you say something like that? We do acknowledge there are some cases, right? Maybe example, very acute incidents of pain where it is very important to identify the source. A patient is very acute. Yes, we have to make sure there's not a fracture. We have to identify what the potential source is. But once we go through those initial screening processes, spending the time to identify the specific source of this low back pain may not all be that important. Okay, paradigm shift, because again, remember, that's the way many physical therapists were trained. Paradigm shift also involves really going from identifying the tissue to focusing on factors that may influence that variation. And in my mind, this is really shifting from a biomedical model, predominant biomedical model, to a biopsychosocial model. And this sometimes doesn't go over too easy with clinicians. This is not an exhaustive list, but potential factors that could influence pain reporting are included on this list. I'm sure we could add some other factors to this as well. Some of these are modifiable. Some of them are not modifiable. Okay. Some of them are modifiable through direct physical therapy intervention. Some are not. For the purpose of this, we're going to focus on really the psychological factors here. So if we go back to our example again, and again, stay with me because this is really the precedence for why we're focusing on this. This is our variability, but how do we make sense of this variability from a clinician's perspective? One way we can make sense of this is we could also look at the same data, but look at it based on these individuals and how they rate their fear of pain in general. Now this highly variable data looks like there's a little bit more meaning to it. And this is kind of an example I often present with our first semester physical therapy students. And I ask them to really just to interpret this figure on the right in one sentence. And surprisingly, a lot of them are able to look at this and say, well, for those that have a higher level of fear of pain, they also have a higher level of pain intensity. So to us, we can kind of make some sense of this, which is why we are really focusing on the psychological factors in this model, because it provides us with an opportunity to phenotype patients. Provides us an opportunity to risk stratify based on these psychological factors. And then from that, we can also think about what types of matched treatment can be provided based on how patients are subgrouped. So what do we mean by patient subgrouping? The overall goal with patient subgrouping, again, imagine this being the patients that a clinician sees over the course of a given time period, let's say a month, okay? And the goal here is to really increase the between group variability, meaning we want those that are red to be very different on certain constructs compared to those that are yellow and those that are green. We also want those that are red to be very similar and share certain characteristics with others that are red, okay? That's really one of the overarching goals for why we consider patient subgrouping. And what this model allows us to do is just that, is to subgroup or risk stratify patients based on prognostic factors, clinically relevant prognostic factors. Because keep in mind, we could do the same thing based on hair color. We could do the same thing based on eye color. But clinically, is that really relevant? And is that relevant to how physical therapists might manage their patients? Which is one reason, like I mentioned earlier, clinicians tend to like this approach because these factors are indeed modifiable. And maybe even more importantly, they are very much influencing clinical outcomes. This is one of the tools. There are a few different tools out there in the literature. This is the one that our group has focused on with low back pain. And another reason why clinicians tend to like this tool, first of all, what clinicians and patients both tell us is we like this tool because it's brief. There's only 9 items. The response options are pretty easy in terms of determining if patients are going to respond with, let's say, 6 different options. They really just need to pick between agree or disagree for 8 of the 9 questions. Now, again, there could be some limitations to providing only those response options, but that's kind of one of the trade-offs with a multidimensional tool as opposed to a unidimensional tool. The burden has to be considered from a clinician and from a patient perspective, and the trade-off might be the specific information that is gathered from a tool like this. But in our mind, this is really like a first-line screening tool. Additional screening could also be follow-up with this, but this is a first-line tool. As we move forward and start talking about treatment, one thing I really want to emphasize, and it's kind of timely because I was just on a call before this presentation and this point came up again, so I will make the point again. One thing that's very consistent with this tool that was developed in 2008, it's a very strong prognostic indicator for clinical outcomes, in particular disability outcomes. So for example, if somebody is classified as high risk using this tool, the chances are they are going to have outcomes that are poorer than somebody that is low risk. And what we've commonly found are these what we call start back risk dependent relationships. It's kind of a stepped relationship where we go from low to medium to high in terms of disability outcomes. So again, from a prognostic perspective, it's a very useful tool. It's multidimensional because it includes psychological items 5 through 9, but it also includes other items that have to do with function, has to do with comorbid location of symptoms. So again, it's not just a psychological measure. The other thing is the psychological constructs that it assesses or screens for are multiple constructs. So pain-related fear, anxiety, pain catastrophizing, depressive symptoms, and bothersomeness. So again, very, very useful tool. Those of you that are interested in how to score it, a lot of the EMRs that the health systems that we work with have it already integrated, so you don't have to worry about scoring it. Clinicians already get the score as well as the risk category below. And what this risk means is the risk for persistent low back pain related disability in this case. The next step would be the treatment, right? Once we identify patients, the next step would be, well, do we treat them differently? Like, why are we doing this? Well, I just told you one reason is for prognostic purposes. The other reason is for the type of treatment that they receive. And what's really neat about this approach is you can see if you go from low to medium to high risk, the way that this model is really set up is that, again, these high risk patients tend to be a little bit more complex in terms of their profile. They may require more extensive treatment, okay? But the low risk patients are really the ones where we're promoting I don't wanna say a hands-off approach, but the approach should really focus on self-management, where the high risk patients really also integrate into the psychologically informed physical therapy interventions that we're gonna talk a little bit about today, which again, keep in mind, are not very common to what physical therapists often provide to their patients. And then the medium risk patients, that's really your classic, what do physical therapists do, okay? This is your exercise, your manual therapy, your other types of physical therapy interventions, okay? And again, I think if we kind of look at the literature in primary care and physical therapy, this high risk group is really only gonna consist of about 15 to 20% of the patients. Again, it might vary slightly based on the setting, but also keep that in mind. Most of the patients that are seen in primary care or outpatient physical therapy are going to either be low or medium risk. So as we go from low to medium high, the interventions kind of build on one another. So let's talk about now the interventions and the different pieces of the pie, if you will. You'll notice here when we give this course that's either related to studies or I'm very happy to say that we have provided this extensive training course to the UF Health Jacksonville rehabilitation system. We actually went through 2 cohorts now. It's much longer than an hour, so keep that in mind. And I say that because we spend an extensive amount of time focusing on patient-centered communication, because we do think this is probably the most important part of this psychologically informed practice approach. What do we do with patient-centered communication? Well, let's use Mr. Smith as an example here. This is Mr. Smith. This is Mr. Smith's background. I'm not going to read it to you. You can kind of glance over some of this, but when you're reading through this, I want you to kind of keep in the back of your mind, is there anything that really stands out here that you as a clinician, and I'm not just talking about physical therapists, I'm really talking about any healthcare provider, anything that really, really stands out that you would be concerned about? And we can have a conversation about that. Right? Some folks might get a little alarmed based on some of the imaging findings. But I will tell you, my perspective is nothing is really glaring to me right now in terms of I should really be concerned about Mr. Smith. Okay. I actually think some of the most important information Mr. Smith is telling me really comes from down here. Okay. And this is important because we could use some of Mr. Smith's responses or his subjective statements to initiate some really focused patient-centered communication conversations. And we'll show you the approach that we kind of recommend to do that. We go on to other findings. Again, I'll ask you the same question. Does anything really stand out to say that you should really be concerned in terms of Mr. Smith's presentation? Some people might say, well, the 10 out of 10 pain ratings are concerning to me, but I don't think anything else really stands out. And I really wouldn't even focus tremendously at this point, other than maybe we can have a conversation about it, but this 10 out of 10 pain. We're going to get back to Mr. Smith in a little bit, okay? What communication skills do we really talk about when we're introducing this concept of psychologically informed practice? We talk about a few different skills, okay? One skill that we spend a lot of time with because we see value in it is motivational interviewing. You also have to keep in mind that a lot of these different communication skills have considerable overlap with one another. I'm going to spend a few minutes really talking about motivational interviewing for the sake of time, and again, keep in mind when we do introduce this, and a lot of the UF Health Jacksonville physical therapists, occupational therapists went through the training, they would actually have time to practice some of these skills and take it back to the clinic then and practice it with patients. And then when we regroup, we kind of talk about some of the barriers, some of the struggles they still have with implementing this in clinical practice. So where does motivational interviewing really fit in with this whole process for change? Because let's think about it. We have these patients that we're seeing with painful conditions, okay? Ultimately, a lot of the behaviors associated with those conditions might be lack of activity, right? Inactivity, sedentary lifestyle. So one of our goals a lot of times in healthcare is to really reverse a lot of that, right? Get that person active again, get them moving, get them to be able to self-manage their symptoms. But there needs to be some aspect of behavior change. Motivational interviewing is a way to initiate what that might look like, okay? So let's start first with motivational interviewing. What this actually is us as clinicians guiding the patient to explore and resolve mixed feelings about changing their behaviors. It's a strategy to help the patient realize some of their perceptions about pain might not be realistic. It's a collaborative and respectful approach, and sometimes clinicians, and I say this only because of past experiences, with clinicians in these training seminars, a lot of times it's difficult for clinicians to let the patient do the work, let them think it through. And that's really one of the key aspects of motivational interviewing is we have to let the patient tap into some of their intrinsic motivation to, for example, recover or get better, okay? It's a respectful approach. We're enhancing the patient motivation towards behavior change efforts. And the example I gave before, what's an example of a behavioral change effort? It may be increased activity. So I like to say that this is really us as clinicians going along and being the tour guide, helping the patient realize the potential. Motivational interviewing gained popularity in the areas of addiction and substance abuse. However, we know that these behavioral change efforts are not only isolated to addiction and substance abuse. They are very applicable to a lot of the pain conditions our patients may be experiencing. It's not advice giving. It's not trickery. It's not directing. And I will tell you, not directing is a lot of times difficult for healthcare providers because let's face it, a lot of times we may have the right answers to a lot of their questions, okay, because of our extensive training and our experience. But we have to step back. We have to let the patient go down that road and seeing if they can find some of the answers to some of these questions. I'll show you some examples. Keep in mind, though, motivational interviewing, just like a lot of what we provide as interventions, may not be for everybody. Those of you that are familiar with the stages of behavior change, if we really look at these stages, who are these patients or what type of these stages are probably most appropriate for motivational interviewing skills? It's probably those that kind of fall under this contemplation stage. Some could argue that maybe some of those in the preparation stage and maybe some in the pre-contemplation stage, but for the most part, it's the contemplation stage. The patients that are up here, right, we may not need to use these motivational interviewing skills because these patients are ready to go. These are the patients that tend to be very adherent to the interventions we prescribe them. They don't miss any appointments. They're very engaged with conversations with their clinician. Quote unquote, they're a pleasure to work with. Not words from me, but words from clinicians in the past. What do these other patients look like? Okay. What do these patients, what are things that we can kind of cue on to say, you know, this could be a patient that's really appropriate for these motivational interviewing skills? We can really listen to some of these cues to questions or conversations. The common one is yes, but. If we hear that term, but, right, where a statement is made, but then there's a follow-up but to that. That could be somebody who's in that pre-contemplation phase. I'm not really sure. I'll try. Not as convincing. I wish I could. Well, we know they could. Okay, if you say so. So it's really some of these cues that we can use to say motivational interviewing may be something we consider for these patients. The strategies themselves, this is the acronym that we kind of present that's common in the motivational interviewing literature, OARS plus. And again, we're spending a lot of time talking about this, but clinicians that are very efficient at these strategies really can have these conversations in a few minutes. Okay, so you keep that in mind. And I want you to think about other interventions or really anything else that you've learned over the course of your clinical training. The first time we learn anything, I don't think, if we're being honest with ourselves, we are fully competent and considered to be experts in that area. The analogy I give with physical therapists that I commonly work with is imagine and remember the first time you learned how to do a manual therapy technique that you weren't comfortable with, a thrust technique maybe on the cervical spine. When you first learned it, right, on a Saturday at a continuing education course, you didn't go into the clinic on a Monday very confident and considered to be an expert in applying that intervention. This is just another concept or strategy that's going to be learned. It's going to take time. I would argue it's even a little bit more complex than some of the interventions because it's a two-way interaction. It's communication. It's responding to other responses from another individual. And a lot of times things don't run as smoothly as they go as we will present them. Okay, so my suggestion would be patient when attempting to implement these in clinical practice. I will tell you, feedback we've gotten from clinicians, though, is after they spend some time and get confident with this, they feel like they have better conversations with their patients. So take that for what it's worth. But I do think that's when I hear clinicians tell me that, it actually is something to kind of take with a grain of salt. It's kind of like why we're spending time really talking about these approaches. Open-ended questions, right? After we're asking the patient for permission to discuss something, and keep in mind, how are we going to start this conversation? I want you to think about things that you probably do regularly as clinicians that you could take advantage of to initiate these conversations. There's some examples of open-ended questions up there in the bullets, okay? And then I would also challenge you to end your interaction with an open-ended question as well. Affirmations are the second stage, and this is probably the most important component or strategy of motivational interviewing. This is where we as clinicians listen for, identify, and comment on positive behaviors. And again, it's not compliments about the way somebody's dressed or, hey, great win by the Gators this weekend, but it's really speaking to the quality of the patient's character and their commitment to recovery. And I always challenge clinicians to really think about doing this once during every encounter. And I also throw it back on the clinicians and I say, think about this when you're in the healthcare environment as a patient. And everybody, I hope, has been a patient in a physician's office or a dentist's office or some other healthcare provider. But let's take healthcare out of this conversation and let's just talk about when you're having a conversation or an interaction with somebody and somebody provides you with a genuine affirmation, it makes you feel good, okay? It makes you feel, quote unquote, appreciated. And this is a very powerful tool to use as part of motivational interviewing. It's also very strongly linked to patient self-efficacy, which is why it is so important and why it is part of this strategy. So again, it's kind of a challenge that I place on everybody, and you'll also see some examples here. If it's difficult to identify an affirmation, I always say something that's really appropriate for everybody, and not just physical therapy, but the last bullet. Just the fact that they're there in your office, in your clinic with you is a good thing. And thank them for that. Because as you know, as clinicians, patients don't need to be there. A lot of patients may not show up. So again, that's something to use as another tool in your toolbox. It's not praise, it's not a compliment. And again, I mentioned the link to self-efficacy. Reflections. What do you as a clinician think the patient is actually trying to tell you? Okay, so this is kind of your hypothesis generation here. Again, this is a genuine reflection. And this, I think, goes a long way because patients will get the impression that you're actually listening to them. How many times have patients told you as a clinician that, you know what, this is the first time I feel like anybody's ever listened to me talk? Okay. That's not saying you're going to give them a half hour to talk about their whole family and their whole life experience, but providing those genuine reflections will go a long way. And it's a sense of building the collaboration, building the trust with your patient, because that's really what we're going into this as, right? We're developing a partnership, if you will. It's a collaborative effort, these motivational interviewing strategies. And then the summary is a chance to bring it all together. This could be used as a transition to a new topic. Again, keep in mind, I probably spent triple the time it would take you to have a normal conversation incorporating all these components here because we're talking about it. But this can be done very efficiently in over a couple minutes. And you'll see what I did on kind of like the last bullet down here, okay? I basically ended off by asking another open-ended question. So this could be kind of moving on to another topic, if you will, right? You don't have to do that, but you could also be strategic in how your conversations go, all right? This is what I wanted you to think about a little earlier, okay? What else are you doing on a routine basis? I hope you're doing it on a routine basis at some level that you can use to initiate these conversations. And I ask this because a lot of times we provide training to folks around the country and we follow up with them 4 months later, and they will tell us that out of everything we talked about, motivational interviewing is something that they're struggling with the most, and the most difficult part is initiating the conversations. So what we suggest is the tools, the screening tools that you use as a clinician. It could be the start back tool like we talked about earlier. And not really just worrying about the risk or the score, but how patients respond to some of these individual statements. This is an example of a printout from the UF Health Jacksonville Physical Therapy or Rehabilitation Department. And this is what the clinicians will see. And they could look at a statement like this. I dress more slowly than usual because of my back pain. They agree with this statement. Can you help me understand why you dress more slowly because of your back pain? Right? We're not questioning how they responded to this, but it's a conversation starter, right? I want to know, what is it about that causes you to dress slowly? Again, I'm not questioning why you're dressing slowly. I just want to know why, right? What's causing you to dress slowly? And a lot of times this is the initiation of the conversation, which again is often the most difficult part for clinicians. Another thing is that I hope a lot of you are using patient-reported outcome measures. And again, we can do the same thing. Based on individual responses to items, that can help us start the conversation. So a lot of opportunities with motivational interviewing. It's a patient-centered approach to rehabilitation. And again, not just relevant to rehabilitation. Keep in mind though, that's who I have a tendency to work with the most. And I was trained as a physical therapist, but I think this is relevant across the board. It promotes patient engagement, which I think is really important. It's an enhanced communication strategy, and it's collaborative. It's a goal-oriented process. We could use motivational interviewing to develop goals with our patients. Okay, and just some important points that I kind of touched on already, but I just wanted to emphasize the efficiency, right? How do we do this? Physical therapists, for example, could do this while they're applying other interventions. Instead of talking about, how the Jaguars did this weekend, which is usually an awkward conversation, we could have a conversation including motivational interviewing skills during the application of exercises or manual therapy, right? So it's all about being efficient. Moving on to another piece of the pie, the pain coping skills. A lot of times, and I've done this in the UF Health Jacksonville system, I've actually taught a lot of these concepts with a clinical psychologist. So I'm going to cover them briefly and just talk about some of the different types of pain coping skills that we've talked about or introduced clinicians to. Keep in mind, a lot of these might be introduced in the clinic, but the goal is that a lot of the times patients are going to bring these home and incorporate them into their self-management approaches. Keep in mind, self-management is not just education, okay? Self-management is an active intervention. And one of our roles as clinician is to really help patients identify what are effective self-management approaches, what are barriers to achieving those approaches, and then importantly, what can we use to measure the effectiveness of those interventions? So again, we're working together. And I think us as clinicians need to play more of an active role in self-management as opposed to just providing our patients with home exercises or pamphlets about posture. Okay, these are some examples of different pain coping skills. And I really like to focus on the last one, replacing cognitive distortions. And one of the examples that we've kind of provided with a patient and a clinical psychologist that I work with, where what the psychologist actually suggested in terms of replacing these cognitive distortions is, and the patient, she worked together with the patient to come up with this. Every time the patient is at a stoplight, I think the patient was involved in an occupation where he was on the road a lot. He drove his vehicle a lot. Every time he was at a red light, and it could have only been for a minute, spend that time to really focus on the positive aspects of his life. Because up until this point, everything in his life was focused on the negative side effects experienced with pain. He never had a time to do anything or think about anything except for his pain, in his words. But this was kind of a start, okay? Every time you're at one of those red lights, spend the 60 seconds to reflect on some of the positive aspects. Just one strategy as a pain coping skill, just one example. Activity-based interventions. Again, just touching on these briefly. not spending as much time as we normally do. Okay, this is where now we go on to the right side of that. And these are now the behavior changes that we're really looking for. And a lot of these behavioral oriented interventions, really two general approaches, focus on operant conditioning and learning, in that all behavioral responses are influenced by their consequences. And the analogy I like to use here is, remember the baby that goes to the doctor's office for the first time. They go into the office and everything's fine until they get that first shot. Next time they go back, they're crying before they even get out of the car, okay? Because it's that operant conditioning, the learning. I know I'm here. I know I'm probably going to get another needle. And what's often done, right? The baby's provided with the child, not the baby, is provided with a lollipop or a sticker. I know the stickers are popular to give out now. Now, are we suggesting you do that with your patients? No. But there's other things that we've suggested physical therapists could do that involve some of the modalities, some of the physical modalities that might not be really supported by the evidence or the research, that we might not use as much. But let's face it, a lot of times our patients really like it. They come in and they want these things, okay? They want the hot pack, they want the cold pack. And ethically, it's okay if we have the conversation with the patient and kind of setting goals. If you achieve this goal, you're going to be able to end up treatment today with the hot pack or the cold pack. Some clinicians get very creative and say, you know, if you achieve the goal, next time you come in to the clinic, you're going to be able to select what music is on in the clinic. So again, it's being creative in how we use some of these operant conditioning learning approaches. The goal here is to provide positive reinforcement for the well behaviors, an example, increased activity, and to extinguish or not provide positive reinforcement. Again, we're not punishing, we're not scolding. And an example of those negative behaviors would be inactivity. Two broad approaches that I want to kind of touch on quickly, graded exercise or activity, and distinguished from graded exposure. With graded exercise or activity, I think a lot of physical therapists might be using these approaches anyway, but maybe not as structured as we're going to talk about. The focus here is that pain is only acknowledged, okay, but it's not focused on. Okay, and again, have the conversation with the patient beforehand so you're not surprising them, okay? And part of the conversation is going to be that they are going to continue their activity in the clinic for a given amount of time until they achieve a quota, even if their symptoms increase a little bit, okay? It's important that we select an activity that motivates the patient. We can kind of get back to that based on the goals that we set, that the patient's involved with. This is very important because it enhances the therapeutic alliance between the clinician and the patient. And how do we identify the activity? Again, we showed the example before about the patient outcome measures and related to goal setting. So again, if something is really motivating the patient, the chances are it'll be a lot easier to integrate that into what we do in the clinic. I mentioned the quota-based system. This is important. So it's not necessarily important to get a pain intensity rating, but once we establish a quota, okay, we're going to walk for 5 minutes on the treadmill at this intensity. Even if my pain increases a little bit, I'm confident as a physical therapist that nothing you're doing on the treadmill, in this case walking, is going to do any structural damage to your spine. Okay, I feel confident saying that as a physical therapist. So if your pain intensity goes up a little bit, we're going to acknowledge it, but we're not going to pay a lot of attention to it. The goal is that we achieve the quota, right? Keep in mind, we're using psychological-based principles here, okay? A lot of clinicians sometimes struggle with this because they don't think it's ethically right to do this. But again, keep in mind, a lot of these interventions are based on psychological principles. And I, again, will say, I'm fairly confident that walking at a low level of intensity like that on treadmills is not going to do any structural damage or damage, period, to anybody's spine. Here's an algorithm and a hypothetical example of a quota. And again, this quota was 2 minutes at level 2. They meet the quota, we progress them. And maybe we progress them at 10%. If they don't meet the quota, again, we don't punish them. We don't scold them. We just maintain that quota next time they come in. Okay, so with graded exercise activity, the quota is the important part. Graded exposure is a little different. Graded exposure is based on fear. So activities patients are fearful of. And again, we have to identify activities that they're fearful of. Patients may tell us right away they're fearful of walking because they think they're going to do damage to their spine, or their neighbor slipped when they were walking and they just had a fusion a couple weeks ago. These graded exposure principles are really based on phobia-based principles. And the common example that we often provide is somebody that's fearful of spiders. Well, the first thing we're not going to do is expose them to a real spider. There's a progression in how they get exposed to spiders. And maybe at the end, they're able to touch a spider. But we're not going to start them with holding a spider in their hand. Again, we could change the dosage, the intensity, the frequency, the duration based on the progression. Again, this gives the clinician and patient a chance to get creative. It's not you must do this. You have parameters that you can change. The key is, as the level of fear decreases, the level of activity increases, and that's our progression. Here's an example of how graded exposure could be used in the clinic. We identify the fearful activities. After that, do they have less fear? And again, that will require us to reassess their fear. If they have less fear, we can increase the activity, maybe use that 10% increase. We don't want to increase it too quickly. If they don't, we don't change the activity level. So the summary, graded exercise or activity are really not based on fear. Exercise that's limited by pain, and the exercise should be something that motivates the patient. Graded exposure is a little different. It is based on fearful activities. And again, we will have to identify what activities the patient is fearful of through either conversation, or there are actually measures that clinicians can use to identify what activities or functional activities patients are fearful of. Okay, so said the same thing in another way. Important that clinicians have conversations with their patients before they try these approaches so the patient isn't surprised. Very important that the patient's on board with this. Impairment-based. Cover this very quickly because in my mind, again, the focus of this talk is how physical therapists could potentially manage their patients, but keep in mind, I think this is relevant across the board to physicians as well, okay? To occupational therapists, right? This is our kind of bread and butter, right? We all have access to clinical practice guidelines. From a physical therapy perspective, there's other interventions that we're not focusing on that fall on this impairment-based, right? This is what their bread and butter is as physical therapists. So we don't teach them how to implement exercises or manual therapy skills, but we do refer to how clinical practice guidelines, can be interpreted. So they have an understanding that some interventions have stronger evidence to support them than others. Here's an example of two interventions and how the level of evidence and recommendations is different. Okay, it's important, I think, that clinicians understand this and how to interpret these clinical practice guidelines, because a lot of times they're a little daunting. They could be 50, 60-page documents when in reality, how we interpret them can really be integrated into single-page decision trees. So we spend a lot of time in making sure clinicians are clear on that one piece of the pie. Self-management, I got into this before because I think it's important, and I like to say a lot of the pain coping skills live in the neighborhood of self-management. This is also important because self-management is a top priority intervention approach for many pain conditions, and I would say many health conditions. I think as healthcare providers, this is probably where one of our biggest opportunities is to take more advantage and become innovative with how we implement self-management approaches with our patients. I mentioned the strategies in that it's more than just education. It's helping patients identify barriers, goals, helping them identify optimal strategies to achieve those goals, and help them identify strategies to measure the self-management effectiveness. Again, it's not just education. This is a really nice reference for those of you that are interested to kind of, provide a little bit more perspective on really how broad self-management can be viewed and some of the essential components or skills, if you will, including things like problem solving, decision making, right? Social determinants of health are becoming very popular now in the literature. How do we tailor our interventions differently based on social determinants of health, right? Maybe we provide additional resources to some patients where we may not need to provide them to other patients. So again, it's considering a lot of this. And this is where I think it's really important to collaborate with others in our health system. Treatment monitoring, this is kind of one of my favorite areas to talk about. And I think this is important because I think in general, healthcare providers don't have enough time to do this. So how do we do this efficiently? The important reason is that a lot of times what we find at the initial evaluation will change, and it'll change early during the episode of care. And those changes should inform the clinical decisions. So for example, we're talking about psychologically informed practice, and our classic outcome measures in this case could be disability measures, but they might not be the most appropriate measures to use to assess how patients are responding to psychologically informed treatment approaches. And we've kind of addressed this in a recent paper that was published in terms of how we kind of, and again, I know this was focused on low back pain, but what we refer to as these time varying factors. And a lot of factors up here in terms of predictors, okay, here are your classic outcomes on the right in the pink box, but then what do we do over the episode of care, okay? And where can we get the most information that's time varying? And what we really suggested here are different coping styles, okay, which really fall under the construct of psychosocial measures, as well as pain intensity. This is a case series that we recently published to kind of suggest, and this is important because classically, this is how physical therapists do a lot of their reassessments. They focus on a lot of these impairment-based measures, range of motion, okay, active movements. And in this study with high-risk patients, again, a small sample size that were receiving psychologically informed therapy, physical therapy, the psychological measures performed better as treatment monitoring tools for disability outcomes when compared to these classic impairment-based measures. So what we suggest is, again, we don't like to be super prescriptive, but what we suggest, particularly for the high-risk patients, how do we reassess them? We provide clinicians with options. Okay, re-administer the start back tool. Okay, you can include self-selected psychological measures. Some of you might be using these already. Okay, another option is a tool that we recently developed for musculoskeletal pain across the board. So again, we provide these options to not be super prescriptive and say you must do it this way, but you should be doing something over the episode of care, as opposed to waiting till the very end when it comes time to determine, do I need to discharge this patient or ask for more time? Okay. And I think what we've kind of arrived at is the minimum, the happy minimum is probably at least every 2 weeks. Okay. Instrumental because it can help us guide treatment over the rest of the episode of care. So as I kind of wrap it up, I want to share very quickly some of the lessons that we've learned over the years related to this topic. Changing attitudes and beliefs of both clinicians and patients is very possible. Changing their behaviors, and now I'm focusing on clinicians and patients as well, is a little bit more difficult. The mentoring for the clinicians is really important, especially for those that don't have a lot of experience or knowledge in this area. I think UF Health Jacksonville in particular and Brooks is ahead of the curve in terms of leadership really getting on board and providing a lot of this training. So we're at the point now where we actually have clinician champions in both of those systems related to this topic. Across the country, though, I will tell you, this type of training is lacking, but it also needs to be pragmatic. It needs to be something that is easily done and easily integrated into a system. And then obviously, we think treatment monitoring is very important. This is actually a paper we published from a large trial that we did. And the reason I put this up here, I mentioned a lot of these things over here on the left, but I think one kind of proof of principle finding that we got from this is the attitudes and the beliefs of the clinicians, even after the training, actually changed from predominantly a biomedical approach, biomedical model, in that we do have to identify the structures, the tissues, to more of a biopsychosocial approach or attitudes and beliefs. And that was really after just an 8-hour training course. The other thing is, over the course of time, clinicians became more confident in implementing this in clinical practice. Keep in mind, this was approximately 500 clinicians spread out through about 5 different cities in the United States. So I think we're learning a lot about how to implement this training, right? I said implement training, yes. How do we roll out the training? The next phase would be how do clinicians actually implement it in clinical practice? Big picture, and I need to acknowledge these folks before I sign off. Dr. George, Dr. Carol Greco, Michael Schneider, and Stephen Wegner, all collaborators with me and kind of from the beginning helped me kind of develop. We've all played a significant role in developing this course and a lot of the content we saw here. But then I think even more importantly, okay, are my collaborators in the different health systems, in particular, the 2 health systems in the Jacksonville area that I really work closely with. Obviously, I have a formal affiliation with Brooks through the UF-PHHP research collaboration, but I'm also affiliated with UF, and that kind of, I guess, marries me into the UF Health Jacksonville community. And I've been really fortunate to be working with folks like Jeannie Bradshaw, Sabrina Wang, and Dr. Sophia Sheikh. If it wasn't for Dr. Sophia Sheikh, I probably wouldn't be doing this talk tonight, but it's really great because leadership at UF Health Jacksonville and then the folks at Brooks Rehabilitation like Victor and Laura and Sarah and Anita have looked at the importance of this topic and now are integrating it into their system, which is a vital step to kind of integrate this and to really change the way that we provide care for our patients with pain. So I think those folks all need some acknowledgement. Thank you.
All right. So thank you so much, Dr. Beneček, for your presentation tonight. I think we'd like to open it up to see if anyone has any questions that they'd like to ask. So again, you can use that Q&A feature that's already in your toolbar for the Zoom webinar, or you can use the chat feature if you have some kind of question, a statement. We can unmute you if you request it as well, if you'd like to ask it verbally. But if you have any questions or anything right now after having gone through the presentation for Dr. Beneček, please go ahead and let us know. And it's something too that I think probably a lot of people would like addressed is if people are interested in this kind of training, Dr. Beneček, is there a way that they can get in touch with your team, or is this an initiative that Brooks is going to roll out, or is it just through research right now?
Yeah, so we're actually doing this with Brooks now. I know we've done it we've done 2 cohorts at UF Health Jacksonville. We usually do 1 a year. Yeah, I think the best thing to suggest is if there is interest, reach out to me. Here's my email, and we could see if we could make something work. I know there's other initiatives being rolled out now to do this on a larger scale, so things are definitely going to be happening over the next year.
Very good. And for additional motivational interviewing resources, are there any specific textbooks or pieces of literature or anything that you would recommend to people who are looking to dig into that a little bit further as well?
Yeah, I think there's some really good textbooks out there. Rolnick and I can't remember the other name. It was on one of my slides, but I think a quick Google search of motivational interviewing, you'll get the textbook. Again, email me and I can give you the resources. Believe it or not, there are actually a lot of really cool YouTube videos that show examples of, poor examples and good examples of implementing these motivational interviewing techniques. So if you are interested in this topic, definitely go online, see what you can find, good examples, bad examples. But again, reach out to me and I can provide you with some other direct resources.
Perfect. And it looks like Caroline was asking if the training is open to DPT students as well, so not just current practicing practitioners.
Yeah, so believe it or not, at the University of Florida in Gainesville, and you would think because of who we have on staff, on faculty there, we would have been doing this for the past 10 years, but we actually just started integrating this into the DPT program. And I think it's only our 3rd year. And I actually provided this training to our DPT students this morning at 8 o'clock. So it was actually kind of timely that we have this tonight, right? So yeah, I think some of the DPT programs are integrating this into their curriculum. I will tell you, there's probably more that are not. And one of the big challenges is always, okay, if we add something, we have to take something away. Now, obviously, I'm very biased, and I think everything we talked about over this past hour is vitally important, and it probably deserves more time. Because let's face it, a lot of our physical therapy students that are trained, not all, so again, hear me out, not all, but a lot of them, when they go into clinical practice, a lot of the patients that they see are going to enter the healthcare arena because of pain. I get it. Others won't, but a majority will, right? It's one of the leading causes of disability in the world. It's one of the most common reasons people seek healthcare. So why we are not dedicating more time, energy, effort into educating our students in regard to content like this and pain in general, always been something that has kind of confused me. But yeah, so that's what we're doing with our DPT program. And I can't really speak for what the other programs are doing.
Perfect. Thank you. I appreciate that. And then I know that you spoke to the fact that you're currently working with low back pain, but do you know if any of your other colleagues are using this approach right now for other types of pain as far as the research goes, if there's any other literature for its use in other areas?
Yeah, so Dr. Sheikh and I actually submitted, and I think resubmitted 2 weeks ago, an NIH grant. We're kind of looking at this for other musculoskeletal pain conditions. So obviously our group is interested in it. I will tell you, I'm working with other groups that are really looking at this for ACL repair, right? Patients after ACL surgery. I know there's another group that's looking at it in other patient populations. And this is what we kind of call beyond the back, right? PIP beyond the back, because remember, it became very popular with low back pain, but 10 years later, where there was kind of an update to this PIP approach, this PIP model, one of the key take-home messages over the 10 years was that there's opportunities beyond the back. So other musculoskeletal pain conditions. Again, I will take it further and say, other patient populations. So yeah, I know there's research groups doing it. You will start seeing a lot more of this in the literature. I kind of have an idea behind the scenes, knowing that there's going to be other types of papers coming out there. So yeah, just be patient. I think just like anything in terms of pain, especially musculoskeletal pain, the low back pain literature usually comes out first, and then everything else kind of follows over time.
Thank you. And if we don't have anything else, or if you don't have anything else that you want to kind of wrap up and share with our participants today, we'll leave it again with Dr. Benechek's email is displayed. And then also you have my information with the AI-PAMI group, Natalie Spindle. If you need to reach out, we can relay and connect you if you missed writing that down. We'll also submit to everybody the recording from this event and the post survey. But any other closing remarks before we wrap it up for this evening?
No, I just want to thank Natalie, and I also want to encourage everybody again to go check out the AI-PAMI website. A lot of great resources on there. I'm really, excited about working with the group, and I think they have a lot of great information on their website. So I encourage you all to go out there, and thank you again, everybody, for spending what is this, Tuesday night with me, first day of December. So thanks, everybody, and have a good night.
Thank you.